I think it's really multifold. I think actually, we've been asking the wrong question for, I think, for decades now. We've asked, can patients access technology? But I believe the better question is, can technology actually improve patients' health? So access is absolutely necessary, but it's only the beginning. So for years, digital health assumed, in my humble estimation, a linear model. If you provide broadband, if you distribute devices, if you can create patient portals, and better health outcomes would naturally follow and flow from that. And that was an important, I believe, first chapter, but it turns out that healthcare is much more complex than just connectivity. And when you look at the FCC, the FCC has done really great work to be able to understand and to estimate, how many people actually have access to broadband. They've said that, about 24, 25 million Americans still lack access to a fixed broadband. And so the infrastructure, remains an important issue. And at the same time, others have said that about 90% or 9 in 10 US adults now own a smartphone. So we've made tremendous progress in getting technology into people's hands, yet, we kind of continue to see disparities in telehealth adoption and remote patient monitoring and, patient portal use, and ultimately, that significantly impacts health outcomes. And the question is why? And I think it's really looking at this as a puzzle. And so we actually published a paper recently in Frontiers Digital Health, where we came up with a new framework as to how to look at the digital divide, and we call it the Resomatic Digital Ecosystem Framework. And the word rhizomatic really comes from this idea of an underground network of roots where every root kind of influences every other root. And if one becomes weak, the entire system suffers. So in that paper, we argue that digital inclusion depends on five interconnected dimensions, right? Where access is just the first. So access in our estimation is, can patients physically connect? Which, based on the evidence that I shared with you, where 90% of people have, some kind of a mobile technology, only 24, 25 million folks who are not connected to stable internet or broadband. So we know that we have tried to. But when we did some deep investigation and we looked at, a portal that Microsoft put up where they said that even though the FCC said that only 24 million individuals actually don't have broadband, that over about 120 million actually don't have adequate, right? And so that's where another issue comes in, where it's not just access, but it's also adequacy. And we think adequacy is the connection fast and reliable enough for telehealth, AI, and remote patient monitoring. But then there's another area, availability. Is the broadband reliable? And is it actually available where the person actually lives? Because, not saying that the FCC or others, kind of, try to pull a wool over our eyes per se. But when you look at just zip code, you can literally be in a particular zip code and there might be broadband available. But if you look at the census tract, that particular individual or family may not actually have access, availability to those as well. So we have access, we have adequacy, we have availability, and then what we've also found is acceptability is another component. Where does the technology fit people's literacy, language, culture, disability, and level of trust? And the last one is affordability. Can patients sustain the cost of devices and connectivity over time? So access opens the digital front door, but I truly believe the other four A's, availability, adequacy, acceptability, and affordability, these actually determine whether patients actually receive care. That's why I believe access was never really the destination, but it's really the first step. And that's why we created this rhizomatic approach, because you need all five A's in order for us to solve the digital divide issue. I believe these are no, I think, defining challenges now of digital health. And I think they fall under, what I had mentioned before around acceptability, right? So technology doesn't improve health. People using technology improve health. So let's say think about a hypertensive patient who receives an alert from a remote blood pressure monitoring, right? So that device works perfectly for all intents and purposes. But now you have to ask yourself a few simple questions, right? So one is, does the patient understand what the numbers actually mean? Can they navigate the application? Is the information presented in their preferred language? Do they trust the recommendation enough to change their behavior? And can they easily contact their care team? So, if the answer to any of these questions are no, then guess what? Then the technology has succeeded, but healthcare has failed. And that is the dichotomy that we have seen in many instances that technology does well, but without the connective tissue to healthcare leading to the necessary positive health outcomes, then there is a mismatch there. So, the U.S. Department of Health, Health and Human Services, they estimate about 9 out of 10 adults struggle to understand and use health information when it is presented in complex ways, which is why for us, digital literacy, health literacy are key components of that. So now imagine that asking those same individuals to navigate patient portals and interpret very complex lab results and values, and they have to upload wearable data, and they have to troubleshoot devices, and they have to understand AI generated recommendations and make informed medical decisions. That's a lot. That is a lot. And so it's no longer a technology problem, but I think it's a human-centered design problem where you need trust and literacy and the like. So digital literacy determines whether patients can operate the technology. Health literacy determines whether they understand the information. Language determines whether they can interpret it accurately. And fundamentally, trust determines whether they will act on it, right? And so technology, for me, I believe it is not a panacea that can cure all, but technology should never require patients to become engineers. It should really, allow them to adapt, and technology should adapt to people's lived experiences and circumstances, and therefore we must design it to serve them. And so technology should really adapt to patients, not force patients to adapt to technology. Great question. So yes, that many of the patients that we worry about today already have smartphones and internet access. So yes, I think I've already spoken at length in terms of those individuals who don't have access, and we are now digitizing a healthcare system that, to be quite honest, unfortunately, leaves some people out of it, and not intentionally, but even the processes by which you set up an appointment and the like. Unfortunately, it is privileging people who are more digitally proficient, more technologically proficient and literate and dexterous. So we have to be careful about that. So that's one bucket of individuals. But there are still some individuals who still have the smartphone and internet access and the like, where I think we still need to really hone in on. And so we see this more so among older adults, individuals living with multiple chronic diseases, rural communities, patients with limited English proficiency, individuals with disabilities, and even younger patients with limited health literacy as well. So there's oftentimes a big misconception where there's an assumption that because someone knows how to use social media or some other form of technological type of artifact, that they know to use digital healthcare. And that's not the case because it requires different skills. So healthcare requires patients to remember passwords and connect medical devices and interpret lab results and understand risks and communicate with clinicians electronically and then navigate insurance information and make informed decisions about treatment. We see this. We created our own remote patient monitoring solution where we have distributed it across a wide swath of individuals in the United States, over 1,500 individuals of all ages. And we found that we provided about 6 or 7 different devices. And there were some people, when they opened the box, they kindly closed it back and said, sorry, this is overwhelming for us. So we had to find ways in which we could provide more support. And so we helped them to develop healthcare competencies to address some of these barriers. And what we found really was this sense of digital self-efficacy where some people just lack the confidence, they lack the trust. It was too much cognitive overload based on what I shared with you when there's some people would open a remote patient monitor and I said this was too many devices, too much, right? Language barriers, fragmented healthcare system, and sometimes some financial constraints as well are key things because not all remote patient monitoring types of treatments are fully reimbursed. And so oftentimes people may want to have to, supplement those costs. And so that's why our framework, the Resomatic approach emphasizes digital exclusion is really caused by one barrier. It's all the myriad of examples and factors that I shared. And it's really the interaction of many barriers that determines whether technology succeeds or not. But there's a way. We've been able to prove that you can actually find ways in which you provide a concierge type of program and system to help patients throughout the process to one, demystify their, what we call technophobia. Not necessarily a fear, but technophobia in terms of this might be too overwhelming for them in terms of the devices. And we found a way to navigate that. And in our remote patient monitoring solution here at the University of Miami, we have a compliance rate of 88% and above. And so we're really excited about those numbers because we've been able to demonstrate through care, through human-centered design, that you can use technology for remote patient monitoring for older adults and for urban and rural racial ethnic minorities. I think this is where digital health has to mature, right? So I don't want anyone, because I think in the previous answers, people felt that, I was saying the issue is with, the healthcare and not the technology. Well, I think in digital health technology, there more needs to be done. So for us in our group, we've spent years, decades measuring downloads and logins and portal enrollment and broadband coverage and app adoption. And those are important process measures, but they are not measures of health. So instead, I believe we need to evaluate every digital health program using the 5 A's that I had mentioned, right? So can patients access it? Is it consistently available? Is the technology adequate for clinical risk? Is it acceptable over time, right? Because that doesn't mean if someone uses it in the initial phases, but it's the long-term use of it. But ultimately, these are still intermediate type of measures. I think the real outcomes are, did blood pressure improve? Did diabetes become controlled? Was sleep improved? Did people take their medications and more adherent to their medications? Did hospitalizations decrease? Because oftentimes, many, ER visits come from acute, uncontrolled conditions, right? Did the clinicians spend more time caring for patients and less time documenting? And did patients become more confident managing their own health? And, and did this lead to kind of overall digital adoption? And so, my humble opinion is that, the endpoint should always be healthier people. And digital health should never be judged by how many people downloaded an app, which some of us techies oftentimes tend to do. It should really be judged by how many lives were improved. Yeah, no, great question. I think we need a mindset shift or a paradigm shift. So for years, we've designed technology around what computers can do, right? And I see that not just in terms of computers, but with AI, right? I think, my worry and fear about AI is that we are pushing healthcare at the speed and at the direction of where AI goes. And I think it should be the latter. It should be where healthcare and life sciences need to go and how AI and other technologies can actually come in and support. So we need to, I think now we need to kind of focus more on design technology around kind of what people need. I'd shared with you earlier the 5 A's in terms of access and availability and adequacy and acceptability and affordability. And we need to significantly ensure that there is equitable access to all, and this may require both policy changes. There needs to be policy in terms of from a governmental standpoint, but also policy changes in healthcare systems as well, and finding other ways in which we can bring the entire healthcare ecosystem on this kind of shared digital technology infrastructure where stakeholders are focused on one major goal, and that is the care of patients. We need to improve availability, expanding broadband into underserved communities. That is critical. And this may require finding innovative approaches, maybe community-owned networks, satellite technologies. Some of the work that I'm doing in the global south as well, finding, these kind of low Earth orbit, technologies to be able to provide that, right? We need to improve adequacy by ensuring broadband is fast and reliable enough for AI-enabled care and remote monitoring and virtual medicine. Acceptability. We need to create multilingual platforms, and it's easy. We have AI now that's generative, whereby you don't have to spend a lot of time actually creating multiple versions of the same platform or web platform, right? You can use generative AI, of course, doing it responsibly. I'm not saying, because I know there are some people who will say the back translation of Spanish to English and from French to English is not always, the most appropriate or accurate. So just want to acknowledge that, but it is a potential tool. We need to improve acceptability, as I said before, and to really improve affordability. Cost is still a huge issue. Um, I am blessed enough to come from a country in Jamaica where, smartphone and cell phone use is democratized and decentralized, and it's cheaper to own a cell phone in Jamaica than it is here. It's easier and cheaper to have mobile technology services in Jamaica than here because you have these very high premium plans here in the United States. Those are some important things that, we can learn from other countries to find ways in which we can increase that. And so, I believe AI presents one of the greatest opportunities we've ever seen, but we have to do it responsibly, as well. And so, I think this is where we can also lean in on kind of precision digital health. So, I don't believe that the future is simply about more technology. It's about more thoughtful technology, technology that understands people, technology that meets people where they are, technology that helps every person, regardless of where they live, who they are, so that they can achieve better health. Because ultimately, digital transformation and any innovation transformation isn't about transforming technology. It's really about transforming lives. And I think our healthcare system, as a foundational pillar of any social services that any country can provide anyone, we need to do better to be able to meet the needs of the patients, of the population, as well as providing as many tools and supports for the people who treat these people so that they can do their jobs well, efficiently, and safely.